This is the IFixYourSciatica podcast. Epidural steroid injections, ESIs. I actually recorded an episode a few weeks ago on what this can do for people in regards to my perspective as a physical therapist and movement specialist. Today's guest is a repeat guest, a very knowledgeable, wise guest, and he was kind enough to share his time with us to explain, as a spinal interventionalist, as a surgeon, what goes into understanding these epidural steroid injections and why they use them. So today I have Dr. Hamid Abbasi. Welcome back.
Thank you so much for having me. It's always a pleasure. I'm
really excited because this is a question that I often get asked a lot, and I can only provide the perspective as a physical therapist. So I'm really excited with you, or with your background in spinal surgery, that how this modality can actually help people. And so for the listeners who heard of you before, and they're seeing you again, give us an update. What's new since the last time you were on this episode, probably about 6 months ago?
Well, there are lots of new things. We have a lots of new projects, but the most exciting part is now that we have developed and progressed in developing our own artificial intelligence system that listen to the patient and the doctor and create a medical record, and that has become really stable, is now commercially out there, and we can give it as well access to lots of people. As a matter of fact, people who are listening to this, if they mention that they are coming from your webpage and your podcast, they can mention that they will get a 6 month free of charge to our artificial scribe system. So our gift to you and your listener. But as well, our surgery center has come along, and we are doing complex surgery in our surgery center. Yesterday, I just visited with a patient from Brazil who's going to come for surgery. So we are not only gaining national, but as well international attention for minimal invasive surgery that we do. But our surgeries are practically at the end of the road if lots of other things fails, like what you do. And but steroid injections are one of those few pillars of management of musculoskeletal, not only spine, musculoskeletal. So I'm very excited today to talk to you about this and then educate the broader public about what they are, how they help, why they help. And so let's start. I'm very excited about talk about that.
Absolutely. And then at the end of this episode, I'm going to ask you a couple of questions about your AI scribe program, because I think it's really important in regards to just overall the delivery of medicine. So we'll go into that. But let's talk about there's steroid injections, which is very common in the musculoskeletal world. You can inject it into a muscle, into a joint, but specifically epidural steroid injections. That's a very specific class, and you need to be a very specific practitioner to be able to accurately inject it. So for the listeners who out there who probably heard about it, they've probably seen maybe a couple articles. Tell us a little bit more so we're all on the same page. What is an epidural steroid injection?
Now, before that, we have to just talk about what is a steroid injection, period, before we talk about what's epidural steroid injection. But then before that, let's have a good understanding. What are the steroids? What are they? Now, let me, if you don't mind, I want to give you just 5 minutes background about what the steroids are. Our knowledge, just in the last few hundred years, that we have become have a method, scientific method, finding things out. For a long time, for thousands of years, we knew that if you eat testicles of other animals, men would have higher vigor and the potency would go up, and they would, like a natural Viagra, so to say. And in 18th century, some people start actually grinding testicles of some animals and injecting it to themselves. And they had the same effect, but lots of side effects as well, until our methods in the chemistry and biochemistry was refined, that we could separate this component of what is in the testicles that give men more vigor. So, and once they found out about them, they found out that is some group of chemicals that they have something in common. What they have in common, we found out much, much later through lots of chemists that worked on that, are two rings. One ring with 6 atoms, one ring with 5 atoms. Later on, we found out about that, but we found out there is a group of chemicals, they have something in common that gives us, and they work on different area of the body, like in woman, they have some effect. In men, they have some other effects, and so on and so forth. And all of them, we found out later, they come from a kind of fat or from a fatty substance, which we call a cholesterol. So nature recycles that. In different area of our body, the cholesterol get taken away. Our body adds some other molecules to it or subtracts something out of it. And then we have a huge group of hormones. Those hormones include all the sexual hormones. Hence, that's how we found out about that people would inject it, subtract that, not the material from the testicles of bulls and other animals to themselves. Almost barbaric, because there are so many other things there, and there are lots of reaction, but it works. And then this group of molecule, we call them steroids. They include many substances that get again transformed into sexual hormones, but as well some other hormones that are not directly related to our sexual activity, but they do lots of things in our body. They practically, this group of molecule, they are like messengers in our body that tells like our suprarenal, our cells in our body, our fat cells, even our brain, what is the status of certain biochemical reaction in our body, like, and how our body should react to that. Now, what we found out is that there are certain molecules, and it's a sad way we found out about that. Like, there are some people who got shot in their belly, and the suprarenal or some glands in the body got injured. We found out they go and they are okay at first, but then next day or next 2 days, the body shut down and they die. And we call that so-called Addison crisis. And that we found out that there's some hormone in the gland above our kidneys that if our body don't have them, literally our body physically shuts down. It doesn't know what to do. Imagine a city that you have cut all the telephone lines, all the internet. So nobody knows what's going on in the other things, that you need water in one area of the city, but you have too much of it in other area, but you cannot distribute it because you cannot communicate. That is how our body actually behaves. It accumulates or gets rid of certain things that we need, accumulates certain other things that we don't need. We literally suffocate and die internally on the biomolecular levels. We as well found out there's a special group of these hormones. We call them now these days steroids, like cortisol or hydrocortisone, that regulates our healing process. Much later, we found out the way these molecules actually work. We found out that this molecule actually goes all the way inside of the nucleus of our cells, and it facilitates expression of some genes, that those genes then produce proteins that then help us to recover from accident, recover in the healing process, recover and induce some cells to come in and heal a damage that possibly done to our body. And hence, we understand now why steroids start working few days, 4 or 5 days later, not right away. Because the way they work, it's not actual steroid that makes the actual effect, but they go to our nucleus of our body, express certain genes that then those genes produce molecules, proteins that then have the actual effect. But because the effect of them is over many, many steps, we unfortunately as well found out they have lots of side effects. Like everybody who has used steroid, they know initially you get actually a boost in your mood. You become sometimes euphoric because it goes to your brain starts being active. But then we have the effect, but we have as well known for a quiet sometimes the chronic use of steroids is really mess you up in many aspects of your body. Nevertheless, we have found out by putting steroid in certain area locally, meaning not taking as a pill. One of the problem is taking pills is that 98% of the medication, whatever you take, goes to entire body, and then only maybe 2% of that goes where you intended to send the material. But we found out that by putting a needle in certain area of the body and giving the steroid to that area, we can give more effect to the area of needed. Hence, we have this steroid injection as a general. So everybody my age probably knows that, when you have joint pain, when you go, one of the first things they do, they put a needle in and put some steroid in that joint. We know that it reduces our immune response, it moderates, it regulates how our body reacts to some damage. It reduces the inflammation, it reduces the how bad our body trying to attack our damaged cells and get rid of them and so on. But as well, we know for a long time that by modulating our immune response, as well, it makes us prone to infection. So practically, the steroids are modulators of our entire body, especially our immune system. By giving it locally with the injection, we are trying to reduce the amount of the systemic effect and increase amount of local effect. And now it comes to where do we put it? If we put it in a joint, is a steroid injection in the joint. If we put it in the epidural space, which is that small space between the skin of the spinal cord and the bone in our spine, that limits practically the effect of that steroid in that location. Obviously, still some of that material get absorbed in our bloodstream, goes to other areas, but that is much less than if we take a pill. Now, actually, have you ever had a Medrol dose pack? Like sometimes when you have joint pain, the doctor gives you a Medrol dose pack.
This episode is brought to you by the Patient Advocate Program. Are you tired of not having support between your rehab sessions? Introducing the Patient Advocate Program, and we're focused on your recovery, and we're offering you 24/7 access to a doctorate of physical therapy. Stop waiting in line to be seen and stop spending hours doing long exercise programs. Imagine being able to get all of your care delivered straight to your phone. Best of all, it's affordable. We believe everyone deserves top-notch relief without breaking the bank. So why wait? Take control of your health today and visit ptpatientadvocate.com and book your free call with our experts. I haven't actually had a Medrol dose pack, but so in 2021, I had a severe allergic reaction. And I was actually given a 7-day pack of, I think it was hydrocortisone. I think I had to take it orally. Yeah. And you're absolutely right. When it comes to the feeling of euphoria, it was interesting because I tracked my sleep and my muscle recovery and everything. And what was interesting was that during that week of steroids that I took, my recovery was actually through the roof. I was actually doing really well. So sorry, didn't mean to interrupt, but yeah.
No, absolutely. No, these are all important information. So the steroids are very efficient, very effective, but they are not free of side effects. And as you described, some of the side effects actually is welcome. Your body wants to have a boost in morale. So it increases your fight and flight response. It increases your reserves in your body. That's what the euphoria is. But then it sometimes can deplete some of your reserves. So chronic use of steroid is always a bad thing. So by us, with the needle, putting it in a very specific location, we can increase the local effect and reduce the systemic effect. Now, the medrol dose pack or hydrocortisone is practically, there are multiple pills that the dosage decreases. You start at the high dose and then you get less and less. And that is one of the things that we found out. Your body gets used to steroid use very fast. The regulation of your body produces some internal steroids. And if you give too much steroid, your brain, part of your brain in your hypothalamus releases another hormone, which is called corticoid the stimulating factor, or corticoid stimulating hormone, that tells your glands over your kidneys, suprarenal gland, okay, we have too much steroid, don't produce too much of it. So if you take a lot of steroid and all of a sudden stop, you get like a hangover thing. So that steroid pack, dose pack, it starts at the high level and it goes slowly down, so your body has time to adjust to that. Now, advantage of steroid injection in your joint is, or in the epidural space, is that most of that material stays locally and it doesn't create that reaction in the rest of your body, or that response that your brain is telling you the rest of your body, don't produce steroid, we have enough of it. But there is a problem there. The problem there is that even local steroid get eventually absorbed in your bloodstream and has some systemic effect. Now, coming back to that, many times our nerves, our joints are complaining because there's too much inflammation is going on. And that is what most of the time steroids do. They reduce amount of inflammation systemically or locally. Now, one of the tricks, and I saw one of your questions, was what kind of other steroids are out there? And that is the beauty of scientists. They have found out some steroid that works right away as good as our natural steroid, but some steroid that have to get metabolized, so, and it takes longer for them, they work longer. But as well, they have found out some combination of steroids that physically, they are like a small little package, and they release the material in the bloodstream or in the surroundings slowly, so-called particulate steroids, so that they stay in the area for weeks and months sometimes, so they give the effect slowly to the area of interest, and they don't get absorbed in your bloodstream, and they don't give a peak bloodstream steroid. So that is the beauty of pharmacology, that we have found out that there are many formulations of steroids that they can practically adjust how much steroid you get to your local needs. Now, steroids are one of the oldest medications that we have used in medicine. And there is almost a comical joke that we say, if in doubt, give steroids. Because their effect is on so many different systems, and there is a level 1 evidence, meaning that the highest level of evidence that if you have inflammation, steroid can actually help you. That's why you give it from Crohn's disease to some neurological disease to some even systemic or local damage to the tissue. And it's actually extremely interesting. You know, sometimes when you have an infection, we talked about that, steroid actually reduce your immune response. So if you give somebody steroid, it's more likely they get infection. But we found out if the infection is extremely severe, sometimes your immune system actually kills you. You have an infection, but your immune system responds so bad to the infection that actually your immune system kills you. So even though steroids reduce the increases our chance of getting infected. In the special, very severe infection, we actually give people steroids. So, that is one of the bottomless pit of knowledge that we have gained in the last 50 years about all the areas that steroid work. And now, nevertheless, I just had a patient yesterday that was very, very concerned that he has read that if you get steroid, like injected a lot of steroid in your body, actually your cartilage become bad, or your bone quality, your bone density reduces, and so on. And all of that is actually true. The chronic steroid use reduces the quality of the bone and the cartilage and so on. But we know that what that really means. I'm talking about people who use for months and years pills and so on that goes to entire your body, and they have systemic effect. Now, for that reason, we try to limit the steroid injection to few times, like 3 or 4 times a year. So in the epidural space, and for people who don't know, our brain and our spinal cord, they have a very tough membrane around them. We call that dura. And literally our brain and spinal cord is swimming in a fluid. We call that cerebrospinal fluid. To keep that fluid in place, there is a really tough membrane around that. We call that membrane dura mater, or dura. Come from Latin, means tough mother. Now, Ashley, have you ever thought about why we anatomically call that dura mater, tough mother? Have you ever thought of that?
I remember learning about this in school, and I remember just the fact that it's truly, one, mothers are the toughest human beings on earth. But also number two, like, this structure does in fact need to be tough because it houses all this cerebrospinal fluid and all this central nervous system. So it has to create a barrier where there's very little exchange of anything.
Now, for a long time, it was forbidden in Europe to do anatomy, dissection. Take a dead person and cut it open and find out how it works. So most of our anatomical knowledge comes from Arabs, from Arab scientists, where they could do dissection. When the Arab the anatomists dissected the dead person, they noticed that around the brain there is really tough membrane, and underneath there is a soft membrane. Wrongfully, they thought that gives birth to our brain. So they called it tough mother and soft mother, which then got translated to Latin to dura mater and pia mater, tough and soft mother. And that is where our naming for dura comes from. Now, the space above the dura, outside of the brain, it's called epidural, meaning above the dura. The space below the dura, it's called subdura, below for subway. You go in the subway, you go below the earth. So space below the dura called subdural space. Space above dura called epidural space. Epi means above and sub means below. So, and obviously for that reason, that space called epidural space, that is where literally the nerves get out of our nervous system to go outside of our spine. But that is where all the nerves are accumulated. So we have learned if you put anything in that space, it reaches many nerves in that area. So, and that is what the epidural space is for, that when we put steroid or other medication, it helps us to reach many nerves in that local vicinity.
Question for you, Dr. Abbasi, because it's such a localized application of medication. Now, when people are dealing with, say, a condition like sciatica, you have multiple nerve roots that are affected, and it can either be the nerve root itself or actual irritation of the spinal cord itself. How does a physician like yourself, how do you determine which level to actually inject into? Because it's so localized, yes, you can, if you're at the highest level, you're going to be addressing the highest level of nerves. But I think a large part, and this kind of goes into when patients speak with me and they say, well, I got the epidural steroid injection and I'm 3 weeks out, I haven't had any effect. It makes me think, is it the right location because it is in fact localized? So what's that decision-making process for you?
Yeah, see, that epidural steroid or epidural space, theoretically, it communicates all along. Literally, there is a space between the bone and the dura that goes around our brain, around our spinal cord, but no different than if you just spill water in your room. It can go anywhere, but in reality, it stays local. We know that if you put it in the lower lumbar region, like lower back, it goes about 2 to 3 levels above and below, and generally doesn't go beyond that, meaning that if you have pain in the neck, you put the epidural steroid injection in the neck. If you have in the chest, if it's in the upper chest, you put it in the upper chest. If it's in the lower chest, you try to put it as close as possible to the area. But in the epidural space, it generally easily goes 2 or 3 levels above and below. But beyond that, it becomes difficult. The same way that if you spill water in your room, theoretically could go anywhere, but realistically stays in some limited area. Now,
okay,
it's very different in the subdural space. In the subdural space, there's literally a lot of fluid that circulates, and that circulation can take it much, much higher. Sometimes women get so-called spinal anesthesia. That spinal anesthesia is actually in the subdural space, where the fluid of the brains are, and that can go much higher up and down, and that can affect many, many nerves and put them out of practically their function. That is why it's very efficient to reduce the pain during the delivery and process and so on. But in the epidural space, generally 2 or 3 levels, spinal levels above and below, is where we expect the effect to be.
Yeah, that makes total sense. And it's good to hear that it is quite localized and be able to see that it spreads. And so what's the decision-making process for you in regards to, you're seeing a patient and they are going to PT, they're doing all the necessary things. What are some of the criteria that you look for to be able to say this patient's a candidate for an epidural steroid injection?
Now, obviously, what you do, physical therapy, is a standard. Everybody has to do that. But how many times have you had a patient that you can help the patient, but everything is so painful, you have to stop. You want to mobilize some muscle group or some joint and so on, and all of a sudden it's so painful for them that you have to stop, right? Wouldn't that be great if you could temporarily take the pain away so they can work with you, so they can get the effect of the physical therapy? That is what the epidural steroid injection can do for you.
Sorry, go ahead.
Yeah, but what is as well important is that we talked about that the way they work, you don't inject it and they start working right away, right? They work about 3 to 5 days later when they start working, sometimes even later. So what is the best way? How can we make sure that we do the injection and you can work with them right away? Because we don't want to wait a few days. So then often I combine local anesthetic and steroid so that as soon as I inject that, the local anesthetic numb up some of the nerve that convey pain. And then while this is working, the local anesthetic is working, the steroid get where they need to go, start the cascade of effect and so on. So the first few days, the local anesthetic working, once the local anesthetic quit working, the steroid start working again. Then I can send them next day to you So you can give them the full benefit and ambulate them, mobilize certain muscle group, do reflex therapy, and give them the full benefit. So practically, if the pain is at the level or discomfort is at the level that we cannot do meaningful activities, including physical therapy, often steroid injection in combination with some local anesthetic can put them on a path that we can maximize the physical therapy and other treatments.
Wow, yeah, it's fascinating. It's good because I know that when I work with some patients, their nervous system is so sensitive that we can't do anything. And so I like to describe it as these patients are experiencing a perfect storm of everything. Their nervous system is extremely irritated, and anything and even at that point, a large part when a patient comes to me and they're extremely irritated, we're focusing on actually down regulating the nervous system. So we're doing activities such as gentle breathing, gentle, great exploded motions to make sure that we're not irritating the nerves themselves. Throughout this entire process, I know that it's not like you go in blind, Dr. Abbasi. It's not like you're going in just like poking everything left and right. One thing I was just very curious of is in regards to determining the area of injection. I know that addresses the spinal levels 2 to 3 above and below, but say, for example, if the nerve irritation is due to a really irritated facet or an irritated disc or some other aspect, does the tissue itself actually dictate the level of where you're injecting?
Absolutely, it does. Absolutely. You have a good perception of the. Now, obviously, you want to get the medication to the tissue that is most inflamed. So for that reason, now sometimes we do so-called facet injections. Sometimes we do medial branch blocks. Sometimes we put steroid in the paraspinal tissue. Like you have an athlete that did a little more than the muscle can take, has a huge muscle tear and everything's inflamed. You identify what the underlying problem is, and you try to be as close to as possible to tissue that is inflamed and is causing the problem. But let's say you're at the stage that everything is inflamed and there are lots of nerves are shooting a bad signal. So where do you want to be? You want to be where those nerves come together, that one injection can give that medication to many, many different nerves. And that place is the epidural space where all these nerves converge to become spinal cord.
That makes a ton of sense. And so here we are. We know that there are some really great benefits because of it's such a localized experience, such a localized injection. Can you tell us a little bit more about what the experience is like for a patient? Say okay, they decided that they're actually getting an injection, and they go into to a clinic like yours. What are they to expect in regards to walk them through what their journey's like?
Yeah, well, generally, these injections are considered a minor procedure. At least in my office, we don't sedate the patient for that. Now, obviously, some situation, if there is really somebody had a previous surgery and there's lots of scarring and getting there is very difficult, requires a lot of poking. Sometimes, but rarely, we do sedate the patient. In those cases, obviously, they cannot just walk away from that. They need somebody to drive them and so on. But generally, it's a 15-minute procedure, and that patient can then, most of the time, can drive themselves afterward if you don't sedate them. Now, obviously, we use X-rays to find out that you're in the right place. For most of this procedure, we get what we call C-arm, a mobile X-ray machine, that enable us in different angle to see where the tip of our needle is. And then there are some other technique, like often we give what we call a contrast, a material that you can see under X-ray very clearly where it is. And for most of the epidural steroid injection, before we put the steroid, we put some what we call enhancing material or contrast, and we see the appearance of the contrast is different if it's in the right place versus in the wrong place. And that enables us with X-ray and contrast to confirm that we are where we need to be. For the patient, for at least for epidural steroid injection, they lay on their belly, we have the X-rays, we clean the area with iodine. And the reason for that is we want to be absolutely sure that we are not introducing any bacteria that is on our skin flora internally. Then in a sterile fashion, we cover everything, we numb up the skin with a very tiny needle, and then we use a bigger needle, longer needle, that goes deeper, and again, we are numbing the tissue so patient doesn't feel most of that. And in experienced hand, the actual injection takes less than 5 minutes. Once we are with the needle in the right place, we get some additional X-ray, make sure we are in the right place. There are some other techniques that we utilize to be sure we are in the right place. Then we give a little bit of a test dose, like minimal amount, that minimal amount of medication, if it's in the wrong place, that it causes some other symptoms that we know. Like, if imagine in the epidural space, we want to be above the skin tough membrane dura. If you give a little numbing medication, there has no effect. But if we are too deep, we are in the spinal area or in the subdural space, or then that little numbing medication make the legs go numb. Then we stop, obviously. So for the person who does that, there are lots of techniques and lots of methods to understand that we are in the right place. But then after that, we slowly give the medication and then take the needle out. It is low complexity, low invasiveness, but even the low invasiveness and complexity in certain areas can be dangerous, especially in the neck. We have to be very cautious to do that. And many doctors who do that in the neck, they don't give local anesthetic, because if you do the local anesthetic in the neck and it's in the wrong place, sometimes can have quite severe consequences. But not giving local anesthetic doesn't give you immediate relief. It's very welcome by patients. So I always give some local anesthetic in all areas. But I heard from one of my colleagues recently that most of doctors in California actually don't give local anesthetic because they are concerned about the consequence of being in the wrong place. So there's not a one right or wrong way, but each of them has its own advantages. But generally, in experienced hand, this is a quite safe procedure.
And what's really interesting is that a large part of determining what intervention to use, it's a matter of weighing the risk versus the benefits to all this. So I really appreciate you sharing that, because it is important I think it's important for listeners and patients to understand the progression as to why they're getting something, because oftentimes if we don't understand the why and we don't believe in it, then the outcomes are actually significantly less. So you said it takes about 3 to 5 days for the cortisone to actually take into effect. So once they get their injection, what are some of the common instructions that you give the patients? Like, is there anything that they need to avoid? Is there anything that you encourage them to do? I would love to hear that. Yeah.
No, obviously, if there is a procedure that they need to be sedated, they shouldn't be eating and drinking before the procedure, because we don't want them to be too sedated, maybe vomit and then get aspiration and so on. And it's always not a bad idea to have somebody to drive you. But generally, for most of straightforward injection, it's not a problem for the patient to drive themselves, but generally it's not a bad idea to somebody to drive you. After the injection, they need to know there are always some systemic effect of the steroid themselves. That you talked about the euphoria. Some people have generalized, symptoms, and even symptoms like hot flashes, and some other, systemic effect of the steroid. The steroid side effects are so variously diverse that we cannot go over that in this short conversation. But generally, they can have very the diverse kind of side effects that patient needs to know. Most of that is harmless though. When we put a needle in people's spine, sometimes we can nick that skin or dura, the tough membrane around the spine, and then in rare occasion, the fluid can leak out. We call that CSF leak. One of the side effects of these injections is the so-called now CSF leak. And then what happens is that when patients especially stand up, more pressure is on the dura, more CSF leaks, and then they start having headaches. That can be even sometimes severe, but that's rare. Now, if something like that happened, we ask the people to lay down, drink fluid, coffee, fluid, and sometimes even we take a little bit of a patient's blood, put it where the injection was done, like we call that epidural blood patch. Because when we put the blood back, it coagulates patient's own blood and like a barrier, prevent the fluid to leak out. So these are things that the patient need to be aware of, that these are possibilities. Obviously, every time you put a needle in people, there's a risk of infection, but that risk is extremely, extremely low if aseptic methods are used during the injection. I myself, knock on the wood, have never had the infection from I've done thousands of epidural steroid injection. I haven't had a single infection from that, but always possible. And then the side effects of that and symptoms can be rarely, it has been described in literature, can be severe because that infection is just next to your central nervous system, like meningitis and so on. But that has been described, but that's very rare.
Yeah, that makes sense. I actually, interesting enough, last month, a friend of mine was experiencing some headaches post having a baby, and going through just some of the symptoms, and actually it turns out that she was leaking even onto her bed sheets. And I said, you should go get this addressed. And so they went to go get the blood patch, and then the symptoms resolved significantly. It was always really, I'm glad that you brought that up, because even though it's rare, right, maybe even less than 1% of a million people, it's
lots of people. Yes,
that's a lot of people. And so
1% of India is still 14 million people, Yeah,
still, that's a lot of people. And so are there any restrictions that patients are on with even just upon receiving, we'll say even within the first 3 to 5 days?
Well, generally, they're not big restriction, but most of that is common sense. We ask people not to do extremely strenuous activity. God forbid, there is a small hole. That small hole can take normal pressure, but every time you do sport, Ashley, you're increasing your cerebrospinal fluid pressure. So if there's a small leak, your regular pressure is okay, but if you do a strenuous thing, you're increasing the pressure, that small leak may become a big leak. So we ask them not to do very strenuous activity, at least for a day or so after the injection. But that's most of the time, that's the extent of it.
Absolutely. Yeah. Well, that's good to hear, because I think a lot of people don't quite know it. In some cases, the experience is so fast, and these patients are going through so much pain that the entire process can be overwhelming. So I'm really glad that we're able to break down, one, what steroids are, why injections versus oral medications, and also some of the side effects and also the effects as well. You said that, so it takes about 3 to 5 days. The second big question behind this is, how long do these steroid injections last?
Yeah, and that is the actually interesting part of it. They take them longer to work, but they can work much longer than almost any other medication because they don't work directly. They increase our internal release of some genes, expression of some genes and protein. That process can go on for weeks and months sometimes, but obviously, generally, there is a limit even on that process, what works. So realistically, we should expect them to work weeks to months. But what I would say to everybody is that this is just to bridge the time until the damage is fixed. So meaning that our body is a living thing, our disc, our joint. They are living tissue. We are hoping in the time that we are reducing the inflammation and giving you some relief, in that time frame, before the steroids are gotten out of your system, your body has fixed the problem. And so, we are not that we think that the steroid stay there for years, but sometimes I do 3 steroid injection and I don't see the patient for years because the symptoms are improved. And we know it's not that steroid that really works years after the injection. It is that they bridge the time until your body fixes the problem.
That makes total sense. And so being able to give these patients time and reduce the pain, obviously because of inflammation, but being able to understand the whole gene expression process, that was something completely new to me. And I'm really glad to have learned that. And I know that my job as a physical therapist is, as once the injection is completed, we actually that's where, as the pain goes down, we can do a lot of work. We can build up the strength, build up the flexibility. I also remember, and we talked about this in the previous episode, how physicians like yourself, when you're doing surgery or you're doing injections, you're actually doing the actual fixing up the tissues, say in the car, right? And reinflating the tires, changing those pieces. And it's my job as a physical therapist to ensure that you're driving that car responsibly. Right.
That's right.
Yeah, because go ahead. Sorry.
And I have to sometimes educate my patient. They ask me, so should I start physical therapy if the steroid doesn't work? No, I say you should start it. You got the injection, your symptoms are less. You should use that time to let the physical therapy work with you and give you the best treatment you can get. So this is not do one versus another. As a matter of fact, if anything, do the injection so you can do a very efficient physical therapy session with your therapist.
That makes perfect sense. And so, Dr. Abbasi, this has all been really eye-opening to be able to break down how this all works. I learned a lot. I think the listeners have learned a lot as well. Tell us a little bit more about this AI scribe. So, I'm just going to share with you, I'm a huge fan of the use of AI in healthcare, especially from a scribe standpoint. Listeners, I know that in the typical physical therapy clinic, clinicians are probably seeing about 8 to 10, maybe up to 20 patients a day, and they might not necessarily have the time to be able to write the note the moment that they actually complete the session. So oftentimes these notes are written from memory. And the challenge is, as much as we want to be able to remember things, it gets very hard, especially when you're seeing all these different patients.
Yes.
And so having an AI scribe like this, where you're actually able to record the conversation, you're actually able to get some real-time data, and you're getting a much more accurate representation, which makes all of our jobs better. So Dr. Abbasi, share with us that scribe more.
You as a provider and I as a provider will provide care. That is why we exist. I have not met yet another provider who loves to sit down after a full day, start documentation. So you just said, at the end of the day, our memory is faulty and not perfect. We create documentation. Sometimes we plain mix the patient. What we thought was for one patient for another patient. For that reason, it is best to do the documentation right after the care. But then there is a problem. Another patient has to wait. And we know patients don't like to wait. So we as provider are in a difficult situation. Number one, do we document right after the care and then the next patient has to wait? Do we document at the end of the day and then our documentation is poor? Or we hire another person that literally document while we are providing care, document it for us. Now, I tried all three of that, and the hiring people, we know how the situation is with the economics of the healthcare can bankrupt the service, and we want to give the best care and so on. Now, wouldn't it be great that artificial intelligence listen to me and the patient while I'm providing care, create that documentation that we have to produce without me have to go at the end of the day, after 5 p.m. until 8 have to sit down and document that without the next patient have to sit in the waiting area and get angry by the minute, or without me spending more resources, hire another person just for documentation. And that is what artificial intelligence can do for us. And this is just in the last few years that we have technical capacity to create a computer system that can listen to you and the patient like an intelligent, listen to it, your conversation, and create a sensible medical record. And that is what we have done. We have a system, we call it Suri, and we call it not artificial intelligence, we call it Suri because it is a smart utility identification, the resource identification system that this artificial intelligence is not only your scribe, it goes and listens to you and create a medical record, but as well helps you to decide what resources can help you best to provide care to the patient. But it is online, it is available, and if somebody is interested, just go to inspiredspine.ai. You have to sign in, and once you sign in and sign up, we send you these days everything has to be secured for HIPAA and so on. We send you a code that you can then use it, and I'm excited about that, but because it helps me to spend more time with the patient. I have so much less hassle to create my medical record, and I have so much more happy patient because they don't have to wait since I have been using it. And I think we cannot go around that as provider. We have to use resources that help us provide better care, faster care, with less resources.
Thank you so much, Dr. Abbasi. Listeners, I'm going to go ahead and put that link into the show notes. So if you are a provider and are looking to actually improve your process and spend more time with the patients, and take a look at Dr. Abbasi's Suri. And what's really great is Dr. Abbasi is the head of Inspired Spine, which actually teaches these really great minimally invasive procedures all throughout the world. So listeners, if you're considering looking into working with Dr. Abbasi or any of his affiliates, I'm going to put his information in there as well. Dr. Abbasi, this was such an eye-opening learning experience. I'm really glad that you took the time out of your day. So thank you so much.
Always a pleasure to be with you, Ashley. Okay. Thank you so much for having me.
Thank you so much for tuning in. We hope you got some help from today's podcast. And for more info, check us out at IFixYourSciatica.com. Have a fantastic and pain-free day. No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.